you going to hear sound?
Yes.
Yes, because that's where the tube is. If you go over and listen to the left, are you going to hear sound?
No.
No. Did that answer that question? Kind of?
Same thing.
Because would you hear anything on the left if the tube's been pushed only into the right main stem?
But the question doesn't say that it was in the right. That was
Right,
far on the right.
it's inferred, so
You know,
careful, it's
that's what
inferred.
my question. I
because-
understand that's what I answered, but
Okay.
it's for me it was like you said most likely to go.
Right.
And what if it went to the left? That was my question.
Well, if it went to the left,
I
then,
know, but I'm about the question.
I know, be careful, make sure that question does make sense. Because I'm inferring you understand that if the tube is pushed too far, where is it most likely going to end up? And so that's what, without saying the tube was pushed too far on the right, because I think that would be a giveaway answer. You know, okay, well, there's going to be sound this side and not this. But so careful. I didn't say specifically that, but again, tube pushed too far. Remember, where is it most likely going to be? In the right. And now you're hearing sounds on the right and nothing on the left.
Because I kept all hypotheticals in mind, so I put like it would most likely end up in the right lung, but there would be no breath sound on whatever side the tube happened to be in would have
Correct.
breath sound on the opposite one.
Correct. That's the correct thing. I like that.
And I think I'm gonna ask that question again,
Yeah,
like, but without saying, you know, like, oh, okay, like, we're thinking the right side, you wanted to say that it went in the left side, wouldn't you say that in the question? Wouldn't you be like, oh, like, this time it went on the left side?
If I was trying to be super, super tricky,
Yeah.
I would have to tell you the tube was pushed too far, and in this example, it would end up in the left.
Yeah.
Okay.
What would you hear? Okay, but that's not where it's most
No, yeah.
likely going to end up. And that's all. That question wasn't trying to be overly tricky or complicated. It's just making sure you understand that if the tube was pushed too far, just based on the angles, it's most likely going to end up in the right, not the left. Because the left angle is a little sharper as opposed to the right. It's a little more of a straight shot, if you will. So good question. I'm glad you guys asked questions. Don't hesitate to ask questions. You may say it's a homework question, so I don't want to ask. You can ask it if it doesn't make sense. Let's talk about it. All right. So this is first part, anyways, touching on chapter 2, dealing with the lungs and chest wall. So there's lots of, I don't want to say lots. There's a fair share of some terminology, some names, some things we need to define and explain what they are. As we go through this, again, anatomical structures, anatomical locations. You will find these first, and I've already posted part 2's PowerPoint. I'm not doing that one today. But you will find as we go through this, and you may think, how many slides did I give you guys? 22, 23, 24? That's kind of big for now. That I'm not giving you a ton of information all in one sitting. And again, method to my madness is I want to give you a little bit of information to let you kind of digest it. When we get to part 2, again, a little bit more information, giving you time to digest that information. As opposed, because if I wanted to, I could really do chapter 2 today, and we can knock it out. Are you going to retain it? I'm worried no, that you're not. Because there is some concepts here that can get a little complicated, and I'd rather us take our time, especially because I consider this a foundational class, to make sure we understand. Next semester, when we do pathology, you need to be able to reference back the stuff we're learning in here, so the diseases make sense when we get to pathology. So sometimes in this semester, this class in particular, yeah, some of the concepts are a little more challenging, but I really try to give you a little bit of information at a time, and then I hold back, giving you an opportunity to absorb it, retain it, and then give you a little bit more information, step back, let you absorb it. So don't think that just John keeps us an hour, hour and a half today, and I know we have 2 hours of class. Why is it? No, it's because the information can get confusing if I was to give it to you all in one big set. All right, so just kind of laying foundation. This semester is all about laying foundational stuff so we can build on top, build those blocks next semester and keep adding to it. Not having to go back from semesters before and reteach the stuff that you should be able to know or retain. And so that's why I kind of give you a little bit of information, and then we start to continue to build on it. Anyways, the lungs. The inflated lungs are conical in shape. Conical is a word that kind of means cone-shaped. I know the lungs don't look like 2 cones in our chest, but they do taper. And that's kind of where the cone shape is supposed to represent. That the lungs do taper. They kind of start narrow and then taper out as they go deeper into the chest. Now some terms here. The apex of the lungs. The apex of the lungs is up here at the top. We describe the lungs and we describe, oh, I hear these in the apex or the apices, plural. That's in the upper portion, top portions of our lungs, as opposed to the lower portion of our lungs that we call the base. So when you're listening to breath sounds, you may see, I'm hearing these in the apices, as opposed to I hear these sounds in the base. Again, bases are lower down at the bottom of the lung. Apices or the apex is up here at the top. The costal rib surfaces, they're smooth, they adjoin the inner chest wall. We'll get to those, again, just inside of the ribs, if you will. The mediastinal surfaces, they're concave in shape and they adjoin the mediastinum. The mediastinal surfaces, or that area of the mediastinum, is here in the middle. And everything that you think about must be behind the chest anyways, the thorax here, the heart, the aorta, the esophagus, the trachea, the great veins and blood vessels there of the heart, all that stuff is found in the mediastinum or mediastinal surfaces. The cardiac notch, that is found, again, this is a picture from the textbook, I'll find it here. Cardiac notch is here. It's where the heart kind of fits into the lung, if you will. Again, there's not a notch here on the right because we know there's how many lobes on the right? 3 lobes on the right, but only two on the left. That left middle lobe, which does not exist, is where the heart actually ends up sitting. And so we can see that sometimes on x-ray. We'll get to those when we look at x-rays down the road. But sometimes you can actually see that indentation or that cardiac notch. All right, the diaphragm. I'll mention the diaphragm today, tomorrow, the next day, the day after that. Multiple times we'll discuss and talk about the diaphragm. But the diaphragm is the primary, the major organ of ventilation. The reason you're able to breathe in and out right now is primarily because of the diaphragm. That's the muscle that's going to pull your lung down, is going to open up and help to expand your lung, and it's that diaphragm that's going to move back up in your chest when you exhale. All right, the diaphragm is the major muscle of ventilation. Don't want to get ahead of myself here, but what would happen to your ability to breathe if your diaphragm was paralyzed? You couldn't, or you couldn't very, very well. There's other muscles, we'll get to those later, but it's the diaphragm that you need to be able to ventilate, to be able to breathe. The diaphragm is dome-shaped. Diaphragm, kind of on this picture anyways, is here, dome-shaped. The right, I'm sorry, it's me.
Just a quick question. So for like the exam and stuff like that, would we have a lot of the pictures and like labeling, or would it be more multi-choice?
Again, most of the questions are multiple choice. I'm not saying I couldn't put a picture in there, or a picture or two in there, and maybe have some things pointed to a certain area and label it 1, 2, or 3, or A, B, and C, and say A is pointing to what structure or what area. Okay, so I could ask that. I tend not to put at least for this, not too many pictures in there, because sometimes getting the quality of the picture and knowing the picture's on a piece of paper, sometimes the quality can be a little iffy, and I don't want to be confusing when it comes to a simple picture. But no, I could give pictures with certain things missing in the label. I think it would be a giveaway if I said, what lung is this, as opposed to this, but I may ask the question, how many lobes are on one side versus the other, that sort of thing. So the diaphragm is dome-shaped. Lower margin located at the 10th thoracic vertebrae, highest margin around the 8th or 9th thoracic vertebrae. This is important to remember, that the diaphragm isn't symmetrical underneath our lungs. It's not symmetrical. The right side is just a little bit higher than the left side. And the reason the right side is a little bit higher is because of this organ that's found right under it, and that's the liver. So the liver kind of pushes up the right side of the diaphragm just a little bit. I know sometimes in pictures and online pictures, everything looks symmetrical. It's not always gonna be the case. So right side's a little bit higher than the left, liver pushes it up, and the heart, being on the left side, actually pushes the diaphragm on the left side down a little bit. Now I think on my next slide here, I didn't really pay attention to it until after the fact. I'm looking, because my focus was, let me give you a good picture of the diaphragm and just its relationship to the lung. But does the right and the left look any difference as far as height? So that's not anatomically correct. The right side's gonna be a little bit higher. Why? Because of the liver. The left side could be a little bit lower compared to the right. That's just because of the heart pushing it down. Okay, so that explains the difference between the two. The previous picture is the picture from your textbook, which I like, but sometimes they over-label some of these things, and they don't need to put all that. I really want you to see the diaphragm, and they give you all this other stuff. It gets a little confusing.
Is there like a hard border between the apex and the base on each side of the wall? Or is this
Not
kind of-
necessarily just in reference to the apex being up toward the top and bases being down toward the bottom.
Basically the interior position of
You're correct. All right, the hilum. The hilum. All right, this is where the arteries, veins, bronchi enter and leave the lung. You can see in this particular X-ray picture where the right and left hilum are. So in this image, obviously you see where the lungs are. So there's the left, and again, remember this image is them facing you, so this is the left side. Left lung, right lung, there's the heart, somewhat centered, but slightly a little bit more to the left. The location here and here represents the hilum. If you think about where all the major airways are coming into and out of the lung, or the blood vessels coming into and out of the lung, most of them are found here. I think my next picture real quick, if I was to take the lungs and separate them and point them towards you, that area, this area represents the hilum. So you can see the airways, the blood vessels, that's where they're coming into and out of the lung.
So that's just referring to the opening that they'll go
That
through?
area, that location, that area, the hilum. Now on x-ray, and I know this class isn't intended to begin interpreting x-rays, we actually have a chapter in the patient assessment class for the end of the semester looking at x-rays and starting to try to do some interpretation here. But I want you to remember that even though this might not be the clearest or best x-ray, you tend to see a little bit more, lack of a better word, fuzziness, haziness around those hilum areas. And you may think, well, John, isn't the lung supposed to be more dark and air-filled as opposed to white and maybe fluid-filled or congested, things like that? Well, the hilum area tends to be have a little bit more whitish areas. And when you say, well, why does that area have more white stuff? Again, think about the blood. The blood fluid is going to be that color, and that's where all that fluid is coming into and out of the lungs. So that location is simply known as the hilum. And there's two, one on the right, one on the left. Again, this image, if you were to take the lungs, right lung, left lung, and then turn them towards you, you would see where those vessels are coming out of the lung. Now the lingula, this is a very thin anterior portion of the left upper lobe that overlaps the heart, the lingula. And so you may think, man, that's awfully low. That's still the left upper lobe. Well, how many lobes are on the left? Two. And what are they called? Left upper, left lower. If you were to look at the left upper lobe, it encompasses this entire area. Where's the left lower lobe? It's down here, and there's more of it on the back, posterior side. So this is still considered the left upper lobe, but this location here that's kind of highlighted, that's the lingula. Anterior portion of the left upper lobe that overlaps the heart, because again, the heart's going to kind of fit into here. Anatomically, it should match to where the right middle lobe is. Again, don't confuse yourself. There's no such thing as a left middle lobe, but there is a right middle lobe. But if one did exist, it would be right at that anatomical location.
So on an x-ray, since lungs are full of air, it'd be hard to see the lingula on it?
Well, it should be air-filled. So this, but to separate what is this versus what is that, it would be very difficult on an x-ray to see it. But you would still see the air in a normal person. right, the pulmonary ligament. This is located just below the hilum, and that's what attaches the lung to the diaphragm. It's the lung surface to the diaphragm. Helps to suspend and stabilize the lungs inside of our chest cavity, that pulmonary ligament. So connecting the lung to the diaphragm that's found just below.
Oh.
Not the clearest picture by any means, but you can kind of see where it goes here. Pulmonary ligament.
Is it like, is it looped around or?
No.
It's not like looped around the hilum?
This, okay, I see what you're saying. No, this is still the hilum, but I wouldn't consider that part called the pulmonary ligament. That's just simply the piece where it attaches here, attaching the hilum and technically the quote unquote the lung to the diaphragm that's found below. All right, so there are pleural membranes that are found surrounding the lung. All right, pleural membranes. They form a sealed envelope around each lung. It is one continuous membrane that surrounds the surface of the lung. There's two, what we call pleura. And there's pleural membranes, but there's two pleura. There's a visceral pleura that membrane attaches directly to the lung itself, the lung parenchyma, the lung structure itself. And then just away from that, closer to the chest wall and really lining the inner chest wall, is the parietal pleura. So there's two surface membranes that are surrounding the lung. One that attaches to the lung, visceral pleura. One that attaches to the chest wall, parietal pleura. You can kind of see it here. If we were to take those membranes and kind of open them up. Parietal pleura is on the outside, visceral pleura is on the inside. Now between those two, all right, so if this is my lung and a kind of zoomed in picture of that location, the parietal pleura on the outside, lining the inner chest wall, visceral pleura on the inside, lining the lung, the surface of the lung. So you have the parietal pleura and visceral pleura. And you have a very, very small, some authors will refer to it as a potential space because it's so small. There is going to be a space between each of those membranes. We call that the pleural space, or pleural cavity, but pleural space is the term you're going to hear most often. Pleural space. What is it? It's that space between the visceral and parietal pleura. So that space in between is known as the pleural space or pleural cavity.
When we have like a pleural effusion, will be in that space.
Yep. Now we're getting there. We're getting there. All right. So normally there is a very, 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 I'm going to say very a few more times, very, 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 very small amount of fluid inside of that space, inside of that pleural space or pleural cavity. It helps to separate those two pleural membranes, the visceral and parietal pleura. So between those two, and going back to the picture here, between those two, that space, there's a very small amount of fluid, an extremely small amount of fluid. It's a very small amount. But what does it do? It helps to lubricate those membranes. It allows for frictionless movement when you inspire, when you inhale and exhale. Allows for frictionless movement of the lung. And it provides cohesive forces to keep the membranes from separating. That's an important thing to remember. It keeps those membranes kind of together. The reason that's important is because the chest wall itself wants to expand. The lung surface wants to contract or restrict, which means there's opposing forces occurring between both of these membranes, the visceral and parietal pleura. They are actually pulling in opposite directions from each other. But with that fluid in there, it keeps, again, those membranes adhered to each other even though there's opposing pull from both of those membranes. So if you were to sit there and actually stick a probe in that pleural space to measure pressure, you would actually find the pressure in that space being negative. It creates a vacuum-like suction, if you will, between those two layers, between those two membranes. And that's us normally. So those two membranes, that pleural cavity itself, it really wants to go in opposite directions. Chest wall wants to expand, where the lungs want to constrict. Think about like a rubber band. You stretch a rubber band, it wants to constrict. Same thing with our lungs. So that's all fine and dandy. That's how it normally works. Another anatomical structure here, the costophrenic recess. Sometimes you'll hear it referred to as the costophrenic angle. This is the lower margin of the diaphragm where it meets the chest wall. The lung itself does not stretch down into this costophrenic space, but the pleural parietal membrane does. And so we'll get to these a little bit more in depth when we begin looking at chest x-rays on our Tuesday class. But just to point it out to you guys here, again, here's lungs, here's a heart, air-filled lungs. You're going to look down here. These areas here are called the costophrenic recess or costophrenic angle. Notice how they are sharp. There should be sharp angles there. That's how it's supposed to look. Again, here's an image. You can kind of see that recess or that angle. If you don't see the angle, then something's going on in that particular space. So you should see those sharp costophrenic angles, costophrenic recess. All right, so still talking about those pleural membranes. Remember there's two, visceral pleura and parietal pleura. Which one aligns the chest wall? Parietal pleura. Which one aligns the lung? Visceral. Okay, so if those pleural membranes become diseased, and I put in here inflammation perhaps. Again, with disease, inflammation tends to follow. Additional fluid can begin to fill into that pleural space. Now remember I said before, normally that fluid that's in that pleural space is a very, 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 very small amount of fluid. Again, just enough fluid to allow for frictionless movement and allowing cohesive forces to keep those membranes together. So normally there's already a very small amount of fluid in there. But if there is disease, if the pleural membranes become inflamed, additional fluid can begin to fill into that pleural space. Additional abnormal fluid can fill that pleural space. And a condition known as a pleural effusion will develop. Pleural effusion. It will begin to settle into those costophrenic angles, which means when you're looking on x-ray, if there's extra fluid, on x-ray, how does the fluid appear? What color? White, because air should appear white. No, so you get all this extra fluid, you start to lose the ability to even see a costophrenic angle because of the effusion that's beginning to develop there. And again, termed pleural effusion. Now, can that fluid get removed? It can get removed, but something has to go into that pleural space to physically remove it. And so, a couple of different procedures here. A thoracentesis is a needle that gets inserted into the chest wall, into that pleural space to evacuate, remove that fluid that's built up. Or a chest tube gets placed, again, into that same pleural space to remove that fluid. And so the fluid can become removed, but it is going to take some sort of intervention, or some may call it a surgical procedure type thing, to have that fluid removed. Absolutely, that could happen.
Is that only going to be if they contract a disease? If they wouldn't have something like that happen with flu? Or pneumonia?
Well, if it was pneumonia, then that's the
Okay.
cause. That's the quote unquote disease, if you will.
Okay.
Maybe disease is too strong of a word. But some sort of condition
Okay.
would cause it. It's not going to happen just out of the blue. Something would have caused it. All right, so pleural effusion. Fluid is in that pleural space. additional fluid, abnormal amounts of fluid begin to spill into that pleural space, causing the parietal pleura, which is located where? Inner chest wall, and the visceral pleura located where? On the lung. That fluid begins to accumulate, forcing the separation of those two layers. Those two layers that are normally right next to each other, right? Very small pleural space between them, or pleural cavity between them. If there's abnormal amounts of fluid, now what happens to those layers? They begin to separate. What happens to the lung itself, the functional part of the lung that participates in gas exchange? It begins to collapse because the parietal pleura, or excuse me, the visceral pleura wants to do what? It wants to retract. Now that we're missing that small amount of fluid and those cohesive forces keeping those two layers together, now this wants to continue to collapse. The lung that's supposed to participate in gas exchange, the air that you breathe in is supposed to get in here, now it gets compressed, smaller and smaller, because more what? Fluid begins to fill into that pleural space. The condition, I still am going to call it a pleural effusion, but knowing what's happening to the lungs, we're seeing the lungs collapse, right? And so, what do you think the treatment would be? I want the lungs to expand, and it's not to give more air here, it's to get rid of that fluid, and then what's going to happen to the lungs? It will begin to re-expand.
So is a thoracentesis or chest tube, is that like, do they only do that after they tried diuretics to see if that would help?
Diuretics are not going to remove this fluid. Not this fluid. Not this. And again, it's due to inflamed or diseased pleural membranes. So no, and there's not really another way to get rid of that fluid without physically going to that space and physically removing it. The other day we talked about patient having did we say pneumonia or something, or secretions that were built up, and we were trying to use the positioning to help drain. Could you just position this patient, stand them on their head, and drain this fluid? No, because the fluid's not in the lungs. Yeah, it's encapsulated, it's trapped in that pleural space. So you can stand them on their head all you want and beat on their chest and say, get that stuff out of there. It's not going to be able to go. That fluid we're talking about when we stand someone on their head or put them on their side or whatever is to get the fluid out of this location, not trapped in that pleural space. Yes?
During a thoracentesis, you can only remove a certain amount of that fluid at a time. I think, because I watched it bedside once, and the doctor said you can only remove like 7,000 because it's too much on the lung if you remove it all.
Which that amount is huge. Is that how many they removed from patients?
Yes, that's how much he removed, and he still had more.
7,000 mLs. 7 liters.
So
This is 500 mLs or half a liter. So 14 of these bottles of fluid surrounding the patient's lung. How expanded do you think their functional part of their lung was? To have that much fluid on the outside? I'd say nothing. Sometimes when you see a thoracentesis done, sometimes they can remove a liter of fluid, or sometimes 2 liters, 3 liters. I've never seen 7. That's a ton. I don't know how the patient was even getting any air inside that lung. Patient, again, scary thing, could also have an effusion on both sides where both lungs are collapsing. So I mean, that's still a possibility too. But when you think about, again, the functional part of the lung, part of the lung that participates in gas exchange, my question down here at the bottom says, what effect would a large pleural effusion have on the pressure required to inflate the lung? So let's just hypothetically say we were using a resuscitation bag, and again, some of you guys I know don't know what it feels like to ventilate a human, but if you squeeze it, it takes a little bit of oomph, but it shouldn't be extremely difficult, right? So you squeeze that bag, you're inflating the lungs, okay? But what if this was our patient? And you try to squeeze, again, is that same level of pressure going to be able to inflate this side? No, so you're going to have to squeeze even harder, requiring more pressure to try to inflate this side. Again, and you can sit there and squeeze and try to put as much pressure as you can. Until you get rid of that fluid, you're not going to be able to really expand that lung. If anything, you squeeze extra hard trying to inflate this side, you're going to end up overinflating the good side. because the path of least resistance, that's where most of the air is gonna wanna go, is the good side. And then the fear is, well, could you pop this lung? Oh, and you absolutely could.
So the lung wouldn't be able to inflate because there's no room for it to go? Excuse me.
Because of
Or like the pressure?
because of the
Decrease vacuum pressure.
constricting pressure that the lung, again, the lung actually wants to collapse. Our normal lung would rather stay deflated than inflated. When we have that very small pleural cavity in that pleural space, those two layers adhere to each other, so it doesn't take as much effort on our part to breathe. But when you begin to separate those layers, the chest wall wants to expand, the lung itself wants to contract. And so this is what it's doing, as more fluid fills that space, it just wants to contract. And again, would make it harder for the patient or for us to try to put more air in here. Because again, the lungs wanting to continue to collapse. The more, and again, depending on the reason, the more and more fluid keeps building up here, it's only gonna make this collapse even more, even worse. Oh, this side's inflating okay.
Right.
It's
so
this
would
side
you-
that won't.
Right, so would you do like a main stem?
No, get rid of the fluid. Get rid of the fluid.
Well, I know you have to get rid of it, but you seem to reinflate it though.
Well, get rid of the fluid, the patient can reinflate their own lung by taking some deep breaths. All right, this was found on page, let me get it here, page 27, that talks about a penetrating chest wound. This is all this stuff, maybe you may think, boy, this is kind of coming from different areas, but it's all related to the same anatomical stuff that we've started in this chapter. So in Clinical Focus 2.1, it says this: consider the events following a penetrating chest wall injury, such as a stab wound. So if someone was to be stabbed, ice pick, knife, whatever the case, bullet even, whatever the case may be, when you penetrate that pleural cavity, what then happens to those layers? The parietal pleura, lining the inner chest wall, still wants to expand, and so what then would happen is this would ultimately want to contract. Air is going to start to rush in to that pleural space. Air rushes in that pleural space. Remember what we just talked about with the pleural effusion? Again, that's fluid. A pneumothorax, which is the word here, pneumothorax, instead of fluid, it's air filling in that pleural space. So the same thing we just talked about with an effusion, fluid in the pleural space, exact same thing's gonna happen, except instead of having fluid here, it's what? Air. Air. So again, stab wound, air rushes in to that pleural space, collapsing the functional part of the lung. Just like a pleural effusion.
Would you have any
can't
issue?
if you can't inflate this lung, the patient's going to begin to experience problems.
Would there be any issue with since they were stabbed with blood? Like,
It's possible. No telling what blood vessels were punctured or torn during said
well,
stabbing.
I'm just saying,
or
like,
event.
would it cause anything like for it to fill with fluid as well?
It could.
Okay.
It could. This is just using just a single issue. We'll get to what it could fill when it fills with blood. So, anybody know? Pneumo means pneumo. Anybody know? I like that, lung or air. They're in that thorax. What do you think the prefix is for blood? I'll get to Chad's question. Hemo. So do you think there's a thing known as a hemothorax? Blood fill. And again, oh, here now it's blood all fill in that space. But ultimately what's going to happen is the exact same. Connor, do you have a question?
Yeah, the name of the bandage is escaping me right now, but we're taught for penetrating chest wounds, basically patch that hole up. Is there a concern that the air that's made its way in would stay there? And is
Oh yeah, because it can't find a place to escape. Yeah, absolutely. It can't find a place to escape. So, temporarily to try to just patch that hole so no more additional air can enter. I mean, that's a good thing. That's going to at least hold off any additional air, but the air that's currently in that pleural space, there's nowhere for it to go. So ultimately, and we'll get to all the treatments and therapies in time, but instead of a thoracentesis, a needle to remove the fluid, a needle can be inserted into this pleural space. You may hear the term needle decompression or needle thoracentesis, to evacuate the air and get rid of the air. And then a bandage, specific type of bandage, to keep that hole closed so no additional air can re-enter. And we'll get into all the specifics of what happens with the pneumothorax and treatment is. I just want to use this opportunity, since we're talking about those two layers, the bad things that could happen if those two layers were begin to separate. Pleural effusion for fluid, pneumothorax for air.
So is there could there be another causation to a pneumothorax besides
Yep,
penetrating
yep,
lung?
yep. Hold on, we're getting there. Thank you for the lead-in. So in this particular picture, you may hear, and we'll talk about this a lot more in depth in the future, open pneumothorax. So why do you think they call it open? Because that pleural space is open to the atmosphere. Again, the stabbing, the bullet hole, the whatever that's caused a hole between here and that pleural space, where air is rushing in to that pleural space. And what's going to happen to that pleural space? It's going to separate further and further and further. That's another term here, open pneumothorax. Now, such a thing exists called a closed pneumothorax. So instead of air entering from out here through a hole in my chest wall, the hole occurred in the visceral pleura, inside the lung. And so instead of air coming in from the atmosphere in this way, I have air that the patient is pulling in, entering that pleural space through the visceral pleura and causing air to fill in this space. So every time they take a breath, more and more air leaks through this opening in the lung surface, the visceral pleura, filling that pleural space.
Is there a condition that causes it?
Okay, so question is, what the heck's causing that? Scary thing to say, but this could be our fault. The respiratory therapist's fault. Something like this was to happen. Again, we'll get into all the specifics down the road, but there's things that we work with our patients where we give them positive pressure. Mechanical ventilator is the easiest example for positive pressure, but there's other things. There's things we're going to actually talk about this semester. Therapeutics we're going to talk about this semester on how to help a patient take in bigger breaths that require pressure. Now, okay, and you guys have actually experienced it. Everybody done CPR, correct? You use the resuscitation bag, practice resuscitation bag. If you haven't, we're definitely going to do it in here. You squeeze that bag, there's positive pressure. You're providing positive pressure. Now the example here is you've given the patient too much what? Too much pressure. And you've caused their lung to, Jeremy? Oh, a softball.
Sound effects.
I need the sound effect.
Oh.
No, the pop. Giving him an opportunity. He's always giving me the sound effects, and the one time. So if I give the patient too much pressure and I cause the lung to pop, thank you, then all that air would fill that pleural space, all right, and continue to fill that pleural space every time the patient inspires. So again, same problem as the open pneumothorax, except there's not a hole on the outside. This hole is actually on the inside. And so it's things we will definitely go over when we talk about the various therapies. And I say, do not put more than X centimeters of water pressure into that patient's lungs, because at X pressure, you could pop the lung. And that's what you could cause.
If you were in the process of doing CPR and ribs crack or break, whatever, could that potentially puncture as well?
Yes, and I'm going to say that would be an open pneumothorax, potentially. Now, open pneumothoraces could turn into a closed pneumothoraces in a matter of a few minutes. So, getting both, and I don't want to get too much into that because we have a whole chapter on that next semester. But again, it's the same condition as far as separating those pleural membranes. An effusion, pleural effusion, is fluid, abnormal amounts of fluid. But a pneumothorax is air that's filling that pleural space. For both, pleural effusion and pneumothorax can become life-threatening, but a pneumothorax is probably going to be more life-threatening sooner. Again, it could happen like that. As air, I don't remember, I have a picture of it. Oh, I do. Okay. Here's the X-ray. Again, sometimes the projection is not the best looking X-ray, but the X-ray. Here's a normal left lung, okay? Dark in color, but some of the white you're seeing there is, again, we do have blood vessels going through our circulation. Pulmonary capillary, so that's normal. Do you see how dark, exceptionally dark this side is? That's air that's in that pleural space. And if I'm gonna use my finger to draw, there's, you can kind of see the border, there's your lung. There's the functional lung that's all what? Collapsed. And all that air on the outside in that pleural space. Now, if that air, and here's the part that potentially could lead to a life-threatening event if not treated, all that air is going to continue to build up. Regardless of cause, whether it was a stabbing or I just gave him too much pressure from my ventilator, whatever, all that air is going to continue to keep adding and filling that space. Once the pressure builds up so high, and you can actually kind of see it here, once the pressure builds up, what happens to the mediastinum and the mediastinal structures? It shifts. It begins to push, including the heart, begins to push everything over. Do you think blood flow, circulation is going to be good when everything that normally should have been kind of centered here is now all crammed over and pushed to this side? No. So you can see some significant issues with the patient's heart rate going sky high, blood pressure bottoming down. Normally we're used to bad things happening, blood pressure goes up. Because again, blood just can't flow through here because everything's so compressed. And it could lead to a potentially life-threatening situation. And you can even see in the trachea, you can kind of see it gets kind of pulled over there. What's interesting is because we're used to where the heart kind of is normally located, somebody had a pneumo on the right, or excuse me, pneumo on the left, how it pushes everything over to the right. So you may see someone's heart over on this side, where it normally shouldn't be, anatomically anyways. Questions?
Is it like this that you can see it through the patient, like without X-ray?
Great question. So there's going to be time, and we'll get to some of the nitpickier things in time. But depending on the severity, if it's severe enough, we probably could identify it at the patient's bedside and not waste our time getting an X-ray. Now the term, I'm trying to hold back because I don't want to say too much. There's a term called tension pneumothorax. That's the life-threatening, that's the critical one. That's probably a patient who's more than likely probably having a tension pneumothorax right now. It's the worst case. Your vital signs are now all affected. That's the pneumothorax that we should technically diagnose at the bedside and not wait around for an X-ray to come back. Because as we're waiting for the X-ray to come back, guess what? What's not happening to the patient's not being treated. So a severe pneumothorax, again, the name is tension pneumothorax, but the severe pneumothorax should be diagnosed at the bedside. And again, we haven't gotten to all the different things we could see, but there are some things we could see right at the bedside without needing the technology of an X-ray to let us know that this guy has a pneumothorax or a tension pneumothorax.
Would you be able to? You'd be able to hear as well. You wouldn't?
If there's no air going into the functional part of the lung,
Yeah,
and that's one of the steps. Guess what you're not going to hear on this side? You're not going to hear any air.
Would you be able to hear fluid though?
Is it fluid?
Oh.
That's right. So there's things we can see. So using this as an example, again, if this is the lung, when you and I breathe in, breathe out, it's this thing that's expanding, right? My lung's like this because of all this trapped air. Do you think you're going to see my chest expanding on this side? No. So that's just a few of the examples of things that I think we have a tension pneumo on said side. You know, and sometimes I don't say it's a giveaway, but when you see a patient with a stab wound or a bullet hole, you understand, okay, pneumothorax is running through my mind. That's what's happening to the patient.
Not to go too far ahead, but is that what's referred to as flail chest?
No, that's something different. But sometimes a pneumo and a flail chest can kind of go hand in hand, but it depends. All right. Now that I got you totally confused, my job is done. All right, going back to blood supply and blood flow going to the lungs. So we mentioned this the other day, that each alveoli does have its own blood supply, pulmonary capillaries that are taking and removing the oxygen from the alveoli putting the oxygen into the alveoli and taking the carbon dioxide and removing it from the alveoli and that being removed from the lungs. So when we have the pulmonary artery, that's blood flow coming from the right side of the heart that's carrying deoxygenated blood going to the lungs. Now we have gas exchange, oxygen is now added to the blood supply, and that goes back to the heart through the pulmonary vein, carrying oxygenated blood. Again, that's part of our gas exchange that normally should occur, and we refer to that as the pulmonary circulation. And that's how you and I, why our blood gets oxygenated there within the lung. Now there is another circulation that does occur in the lungs. That's known as the bronchial systemic circulation. Now, this circulation is to supply the lung parenchyma, or the airway walls, with the oxygen and nutrients the lung or the airway walls require to function. So there's oxygenated blood that is coming back from the pulmonary vein will mix with some of the deoxygenated blood here. And so when you see this location, we call this area a shunt. So you are going to have some of this oxygenated blood mixing with this deoxygenated blood in the pulmonary artery going to the lungs. And that's okay. That's how it normally functions. It's because this terminal bronchial, for example, this airway wall needs its own oxygen supply, its ability to function, just like every single tissue in our body does need oxygen. Whereas the pulmonary circulation is occurring here to get the rest of my body the oxygen it needs. This bronchial circulation is simply to supply the airway walls with the oxygen that it needs. But there is going to be some mixing of oxygenated and deoxygenated blood together. And that's okay, that is normal. We refer to that as our own kind of anatomical shunt. And we'll get to some examples where that may come into play a little bit more later. Speaking of blood supply through the lungs. All right, so let me go back, using this picture as an example. Deoxygenated blood coming into the alveoli or around the alveoli in that pulmonary circulation. Gas exchange is occurring, oxygen's being added to that blood supply, and now that's going back to the heart, and that oxygenated blood's being pumped to the rest of the body. Okay. If there is an embolism or a blood clot, everybody's probably heard of a blood clot or an embolism before, right? It's simply a blood clot in a blood vessel somewhere. But if an embolism was to develop in the pulmonary circulation, okay, so now I have a blood clot where blood is supposed to be flowing into my lungs. If there is a blood clot, which is possible, and if that blood clot is occurring in my lungs, that's going to prohibit or not allow blood to continue flowing through that location. We call that a pulmonary embolism. Pulmonary embolisms can be very dangerous, very life-threatening. The patient could result in immediate symptoms of the patient as far as sudden, immediate shortness of breath because blood flow is being blocked. So, probably not the best picture. Let me go back to this one. If I had, or let's just hypothetically say, a blood clot right there. A blood clot right there. Is any blood going to get, any deoxygenated blood going to get down there to be oxygenated? No. And so the patient, depending on how many alveoli are affected or location is affected, could turn into a certain level of symptoms. Again, if it's really, 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 really deep far in the lungs where it's not obstructing too much blood flow, patient potentially could be asymptomatic, not have any symptoms. But the more alveoli that are being affected because of that blood clot, again, can lead to very dangerous, very emergent issues with our patient. Again, the word pulmonary embolism is a blood clot in the pulmonary circulation. And we'll definitely go into details about that further. Blood clot's a good thing? Absolutely not. I want blood to freely flow throughout my body. If there's a blood clot in my pulmonary circulation, that could prohibit my body from getting blood that's been through the gas exchange and picked up the oxygen that I need. Pulmonary embolism, a pretty bad thing that could happen out there today, yes. You know who it's more likely to happen to? I hear athletes, I hear smokers.
Women on
I
birth
definitely
control.
say yes to smokers, it could happen to, but something even more simple. Something even more
Divers,
simple.
wouldn't divers?
Could happen to divers, but even more simple than that.
Women on birth control.
They're in the risk category, yes. But an even simpler example, somebody who's been sitting stationary for long periods of time. What can happen to
You're
your
putting us at
circulation in
risk
your
right now.
lower extremities, in your legs?
It slows down.
Circulation
Yeah.
slows down. What can begin to form? Blood clots can form in your distal extremities. Anybody heard of DVT? Deep vein thrombosis. That's a blood clot that occurs in your lower extremities from just lack of ambulation, lack of movement. That DVT, that blood clot that's in your lower legs, a little piece of it breaks off. Where does it go? It's going to travel back to the heart. Heart's going to take that, pump it into the lungs, and now it's stuck. And so, and who sits for long periods of time? I'm looking at you guys, been sitting for hours on end.
Truck drivers, pilots.
Okay, truck drivers, pilots, heck, anybody who's flying great distances. What's the longest flight anybody's ever been on before? Single sitting for
8 hours.
8 hours.
22 hours.
Tell me again.
22 hours.
22 hours, where you're basically just sitting the whole time. Yes, those things. So here's your patient. You're called down to the ER for a patient who's complaining of shortness of breath. And in that quick history, well, what have you been doing today? Well, I just got off a flight from the other side of the world. Again, where you've been sedentary or stationary for long periods of time. Yeah, you're at risk for a pulmonary embolism. Do you think we have hospitalized patients? I know we talk about ambulation today. We want to get them up and get them moving. But do you think there's patients that just can't? They're in a comatose state. They can't get up. They can't move around. They're in a comatose state. They're in that same bed for days, weeks, months on end. Again, we're worried about bed sores and all that other stuff. But what's another thing that could develop? A blood clot. That's why, anybody know what medicine they're given? Shot in the stomach. And what's the med? Heparin, a blood thinner, to try to prevent clot.
I was talking about sequential compression devices.
Yeah, compression
Yeah,
stockings,
also
those sort of things
compression.
that can help to aid in circulation. Help aid in circulation. All right, saying too much because there's stuff I just said I'm not going to quiz you guys on. But was there any questions before I move on to the next thing here? Pat, you okay?
No, yeah.
Okay, Mackenzie, you okay?
It's not really a question, but I do actually have a picture of a PE on my phone because I was in a cath lab and we had
Yeah,
one
see
of
one,
those.
yeah. I do too. I have all kinds. We'll get to those in time. But yeah, we've seen some bad ones, really, really bad ones where there's significant clots.
Would paralyzed patients be at risk of that,
Yep,
right?
absolutely. Just think about it. If you're not moving,
But
blood
don't they do like
flows.
massages and stuff for that?
Yeah. They can do compression stockings, range of motion exercises, something. What are you supposed to do if you're forced to sit for hours on end, like today, or on a plane where you're flying? Get up and walk when you can, or at the very least, I see feet doing this now. Yeah, just move your feet, stretch, keep them moving. That's only going to help blood flow, as opposed to just keeping them still, flat, and stationary.
After you got the clot, don't move. Until you get the blood thinners.
Right. All right, so last part here, lymphatics of the lung. All right, lymph fluid is typically a clear protein-containing fluid in the interstitial spaces all throughout our body. this fluid does come from the blood that's in our capillaries. And normally, these capillaries, which are very porous, so it allows fluid to move back and forth, filter about 30 liters of fluid per day in the average adult. 30 liters of fluid per day out of the blood into those interstitial spaces in your typical adult. So, if that amount of fluid is filtered from the interstitial space, 23 of the 30, or excuse me, 27, where did 23 go? I don't know. So 27 liters of the 30 does get reabsorbed back into the capillaries. Okay, so there's this constant exchange of this fluid. Normally it's how it works. But what happens to those 3 liters that doesn't get reabsorbed? It is cleared by our lymphatic system. It helps to clear that excessive fluid. And again, that's perfect. That's how our body works. Keeps that excessive fluid gone. That 3 liters that the lymphatic system helps to simply remove. However, if for some reason in the lung our body couldn't clear that extra 3 liters of fluid, where's that fluid going to ultimately end up? It will end up in our alveoli, flooding our alveoli with fluid. Because normally in the alveoli, there shouldn't be fluid inside the alveoli. That's supposed to be the air, right? Fluid could leak into your alveoli. Now, do you think gas exchange would occur in your alveolus if the alveolus was full of fluid instead of air? No. We haven't perfected the way to get oxygen and carbon dioxide to move through fluid. If there's fluid there, it's not going to be possible for gas exchange to occur. Maybe in my picture here, there's an alveoli that's clear. Okay, so gas exchange could occur normally here, but it's going to be impaired any spot there is fluid. Obviously, that one's going to be the worst. Question?
When you say the body clears it, you mean it goes back into the blood?
Correct. Correct.
Now, like when you have a patient, like little grandma over here, and like people sometimes use the term weeping, like their arms like kind of like bleed fluid. Is that from the lymph, or is that some other fluid?
It can be excessive fluid that's there, but in this case, it's occurring in the lungs. The term pulmonary edema. Be careful, because we talk about lots of P words and words that deal with fluids, right? Pulmonary edema, pleural effusion are different. Going back to pleural effusion, that was fluid, yes, but where was that pleural effusion fluid found? In the pleural space. Pulmonary edema is this excessive fluid that ends up where? Inside the alveoli. And so when this happens, again, floods the alveoli with fluid, gas exchange cannot occur very easily the more and more and more the fluid builds up. The edema builds up. So what will we do for our patient? Probably initially we put them on oxygen, trying to give them as much oxygen to those alveoli that are quote unquote normal, but it's not going to do anything for these. I'm sorry. We give them diuretics, fluids to help them urinate, pee, hopefully removing this excessive fluid. And again, we'll get to the causes of these things later, but temporarily put them on oxygen and give them something to help eliminate any excessive fluid, like a diuretic. They can go to the bathroom, which is going to help clear that excessive fluid. Now, I will say, and I don't want to get too much ahead of myself, because I know we have a class eventually talking about this, but we need to figure out what the primary problem is. Because if I don't fix the primary problem, guess what's going to happen? All this is going to come back. And so we do have to be mindful, yes, this is a temporary fix, the diuretics to help them eliminate, and the extra oxygen just to help support them. Until that gives me time to figure out what the problem is. So now we can then treat the problem so it doesn't happen. But if I can't figure out what's wrong with the patient, this fluid's going to simply come back in a matter of time. And not a week later, no, it's going to come back probably in a couple hours. But I wanted to do this one also today because when we talk about fluid in the lungs, pleural effusion, technically that's fluid in the lungs, I guess, even though it's pleural space, not the functional part of the lung. Pleural effusion, pulmonary embolism that has the initials what? PE, And then I'm giving you this one today, pulmonary edema, that also has initials PE. I can understand confusion if this is the first time you've ever heard of any of these conditions. Okay, so it's why I'm kind of giving you a little taste. I will say, and I didn't talk about it with the pulmonary embolism, we call a pulmonary embolism PE for short. We do call a PE, a pulmonary embolism, a PE. We don't call pulmonary edema PE. Again, you see the confusion. But what do we call this? Pulmonary edema. I will say it all out, all the words. Pulmonary edema is what's happening here. Pleural effusion is pleural effusion. Again, not abbreviated PE. The only one that we abbreviate PE is a pulmonary embolism. Questions? Oh, my last slide one. Okay. I'm thinking in my head, okay, what's next? That was it. All right, questions? Questions about any of those conditions that we talked about today? Yes?
Why does the fluid settle in the alveoli?
It's because again, shouldn't, right? But the capillaries are so porous, and it's easy for diffusion to occur amongst the alveoli that the fluid, and again, it's also dealing with pressure in the system, in the pulmonary circulation system, that sometimes just simply pushes that fluid out of the capillary from the interstitial space into the lung itself. This is one of those situations, even though this is in the lung, I'm not going to turn the patient on their side and try to get that to drain out. No, that would be a bad issue with pneumonia or secretions or something like that. That's not the treatment for this.
Going back to like the pleural cavities, if the serous fluid in the pleural cavity, if that depletes somehow, is that like the pleural rub? And
Good question, good question.
Can you hear that and like can the patient feel that?
Okay, so the question was back to the pleural membrane surfaces. Again, very small area of the pleural cavity, pleural space, if you will, that normally contains a very small amount of fluid. We talked about in diseased or inflamed surfaces, how they could separate and abnormal amounts of fluid fill. Question was, well, what happens if that very small amount of fluid is now gone for whatever reason? There's just not enough fluid there. What happens with those two surface membranes? They stick together. Now when the patient inhales, what happens? They rub together. So the patient could experience chest pain, pleurisy, pleural chest pain, and the breath sound. And I know we haven't talked about this in class yet, and we will in time. You may hear a breath sound known as a pleural friction rub when those surfaces are rubbing together. And so you can actually hear that with the stethoscope if someone has a pleural friction rub. You guys talk about pleural friction rubs in lab yet? I heard you guys were listening to some breath sounds the other day, right? Okay. Didn't know if pleural friction rub was one of them, but again, if you hear a pleural friction rub, it's those two surfaces that are now rubbing together because there's not enough of the normal fluid between the two. Again, that small, very, very, very small amount of fluid between those two allows for frictionless movement. But yeah, we've definitely seen patients that experience that and have very specific chest pain. And I'm not trying to get ahead of myself here because looking ahead for what we're talking about tomorrow, but patients who experience chest pain from that very fact, what do we initially think may be happening, or what we initially want to rule out? That they're not having a heart attack. And so, yeah, so that definitely could potentially happen.
Can that rupture the pleural, like the layer,
Mhm.
because of friction?
Mhm. Questions? All right, so I got a few questions for y'all, as I normally do. All right, so my question for you guys, and there's 3 today, just 3. All right, what is the name of the condition where air gets trapped in the pleural space of the lung or on the lung? Pulmonary edema, pleural effusion, pneumothorax, or pulmonary embolism? Air getting trapped, that's a pneumothorax. So C is the correct answer here. Pneumothorax. Air trapped in the pleural space. Okay with that? Get that picture all right? All right, next question. What's the name of the condition where fluid gets trapped in the pleural space of the lung? Is that pulmonary edema, pleural effusion, pneumothorax, or pulmonary embolism? This one is pleural effusion. For a second there, I didn't even think I hit the the button, I forgot. Air, pneumothorax, fluid, pleural effusion. Again, fluid trapped in that pleural space. So that was question number 2. It's up there now, question number 2. All right, last question. Which pleural membrane directly covers the lung, meaning the innermost layer? Is that the parietal pleura, visceral pleura, shunt pleura, hilum pleura? I just made up a bunch of pleura names. This one's visceral. Yes, visceral pleura. Innermost. It's the one that lines the lung. What's the parietal pleural line? The inner chest wall. And shunt pleura, hilum pleura I made up. You couldn't tell already. You know, sometimes, especially when we get test questions, I need more wrong answers. What am I going to pick? I try to get creative and see who I can sucker into picking one of those wrong words that we've never said before, but try to get creative. So for this class, this next test, we're in chapter 2. Wednesday I'm doing chapter 2, part 2. The following week is chapter 3. Chapter 3 has 3 parts to it.